My name is Saul Johnson. I'm the head of the health practice at Genesis Analytics based in Johannesburg, South Africa. And welcome to this symposium. It's a slightly strange experience. I'm doing a symposium when I don't have lots of people in front of me. So I hope that you will enjoy the session. This is a symposium titled HIV Epidemiology in Southern Africa, Critical Questions and New Methods. We've got two interesting and I hope you will find engaging presentations. The symposium is being jointly hosted by the MOHCCC Consortium, which is Measurement and Surveillance of HIV Epidemics, which is hosted by the London School of Hygiene and Tropical Medicine, as well as the HIV Modelling Consortium, which is hosted by the University College London. And both of these consortia are funded by the Bill and Melinda Gates Foundation. The aim of both of them in their own way is to strengthen the collection, the analysis, and the use of HIV data to better understand trends in HIV incidence and trends in the epidemics in key locations, particularly in Southern and East Africa. Some of the key partners in this consortia are CeSHHAR in Zimbabwe, SIDA at the University of Cape Town, and UNC Chapel Hill, their project in Malawi. So this is the first part of a two-part symposium. There is a pre-recorded session, and I would urge everybody to go and view that pre-recorded session with Professors Hargreaves, Phillips, and Hossainpour. And that is available on the IS and MOHCCC websites. So with that brief introduction, I would like to commence with the first presentation by Leigh Johnson. And Leigh is no relative of mine, but he is a senior researcher at SIDA, the Center for Infectious Disease Epidemiology and Research at the University of Cape Town. And many people may know Leigh for his many years of work on HIV epidemiology and modeling, and a lot of work that he's done on the Tembisa model in South Africa, which is used very widely. Leigh, without any further ado, I'm going to pass on to you, and you'll have 20 minutes for your presentation.
Hello, everyone. So I'm going to be speaking to you today about new data sources for modeling HIV incidence in African settings. Unfortunately, I'm not sharing my video with you because my internet connection is not great. But just to give you an overview of what I'll be covering in this presentation, I'm going to start with a few introductory comments on the importance of modeling HIV incidence. I'll then present two paradigms for modeling HIV incidence, one based on survey data and the other based on case reporting data. In both cases, I'll talk a little bit about the challenges we face in using these approaches and the potential for new data to move us forward. I'll then talk very briefly about geographic differences in HIV incidence and incidence estimation for key populations. And I'll finish off with a summary of some of the key ways we need to move forward. So just by way of background, I wanted to present this slide showing HIV incidence reductions over the period from 2010 to 2018. The dark blue bar is representing the global average. UNAIDS estimates that over the 2010 to 2018 period, there was about a 16% reduction in HIV incidence. The red arrow is representing the UNAIDS target, which is a 75% reduction in HIV incidence over the 2010 to 2020 period. And the bars to the right are representing the incidence reductions in different regions. And what you're seeing here is that although there's some variation across regions, none of the regions are really anywhere close to achieving that 75% reduction. So progress towards the incidence reduction target has been pretty dismal. And although this slide is really speaking to the importance of advances in HIV prevention, I think it also speaks to the importance of developing improved methods for estimating HIV incidence so that we can monitor progress towards these targets more accurately. So why are HIV incidence estimates important? They're important, as I said, for tracking whether HIV prevention programs are having the desired impact and for monitoring progress towards the UNAIDS targets. They're also important for predicting future resource needs. The number of people we will need to treat in 10 years' time is going to depend very much on incidence trends today. Incidence estimates are also important for identifying the subpopulations that are most at risk and most in need of targeted interventions, and also for identifying the regions in which HIV prevention efforts need to be intensified. Modeling is one approach that we can take towards estimating HIV incidence. There are other methods. The UNAIDS estimates that I presented earlier were based on mathematical modeling. And this is really the most widely used approach to producing HIV incidence estimates globally. Most of the other data sources only provide us with an incidence estimate at a point in time or over a few time periods. And the major strength of modeling is that it provides us with a full time series. Some of the other data sources only provide incidence estimates in a specific location, and it can be difficult to generalize from that. And importantly, there's no single data source that can provide us with all of the incidence estimates that we need. But by combining different data sources within a modeling framework, we can produce a larger set of incidence estimates with more precision. So as I said, we currently have two broad paradigms for modeling HIV incidence. The first approach is the survey-based approach. So this relies on regularly conducted HIV prevalence surveys, and increasingly those surveys include recency testing. Some of you may be familiar with the EPP and AEM models, which are examples of software used under this approach. And this approach tends to be applied in the countries of sub-Saharan Africa. The second approach is the case reporting approach, which relies on routine data rather than survey data. So the main data sources are annual numbers of new HIV diagnoses and recorded numbers of AIDS deaths. Examples of software that are used here are the CSAVER and ECDC models. And this approach tends to be applied mostly in concentrated epidemic settings. It is important to say, though, that there's no reason why you couldn't use a case reporting approach in a sub-Saharan African setting. And vice versa, there's no reason why you couldn't use a survey-based approach in a concentrated epidemic setting. We might not have the data that we would need in order to apply these methods, but there's no reason why you couldn't collect the data that you would need in order to apply these methods if you wanted to. And a number of sub-Saharan African countries are interested in setting up case reporting systems, which suggests that in the years ahead, we will need a more synthesized approach towards estimating HIV incidence. We will need an approach that really integrates these two modeling approaches into a single model. So I'm going to start by going into a little bit more detail on the survey-based approach. And I want to start by saying a little bit more on recency testing. As many of you will be aware, there are a number of new assays, such as the LAG assay, that can identify which HIV infections are recently acquired. There is, though, the problem that there is a significant risk of false recent results in individuals who are on ART or virally suppressed. And this means that it's necessary to combine the LAG results with results from other tests, such as ARV biomarkers and viral load tests, in what's called a recent infection testing algorithm, or RITA. Usually the RITA would exclude from the recency calculation the people who have ARV biomarkers or who are virally suppressed. And together with assumptions about the mean duration of recent infection, or MDRI, and the false recent rate, or FRR, the RITA would then provide us with an estimate of HIV incidence at a population level. And this incidence estimate would be used in model calibration. The RITA approach has some limitations. Most significantly, the incidence calculation often doesn't reflect the uncertainty around the MDRI and FRR parameters. Also, prior knowledge about plausible age and sex patterns of HIV incidence is not incorporated. So, for example, we know in many Southern African countries that the ratio of HIV prevalence in young women to that in young men is around 2 to 5. And so if your RITA estimate of that ratio is outside of that 2 to 5 range, it might be a red flag that there's a problem with your FRR or MDRI assumptions. And then another limitation is that excluding the LAG positive specimens that are ART positive or virally suppressed ignores the possibility that a recently infected individual may have started ART. And this is increasingly an issue in the era of universal ART eligibility, and with high rates of HIV testing, it is quite possible that some of you recently infected individuals may have been diagnosed and started on ART. And if you assume that nobody who's on ART is recently infected, you could be underestimating HIV incidence. So one possible way around these approaches is to adopt a Bayesian approach to estimating HIV incidence using the lag data. So the idea here is that rather than calibrate the model to RITA-derived incidence estimates, we calibrate our models directly to the raw lag data using a Bayesian approach. And the idea is illustrated in this next slide. The solid blue arrows here are representing the current approach, where we start with the numbers of lag positive specimens. We exclude those in which there are detectable ARVs or viral suppression. We then assume fixed MDRI and FRR parameters, and the RITA then gives us an HIV incidence estimate. And we then calibrate our model estimate to try to match that survey estimate of HIV incidence. The alternative approach, which is represented by the dashed arrows, is to calibrate our model directly to the lag positive data stratified by ART status. And importantly, instead of assuming fixed MDRI and FRR parameters, we specify prior distributions to represent the ranges of uncertainty around those parameters. And those distributions get updated based on which parameter combinations give us the best model fits to the survey data. The other important issue that I want to mention in the context of survey data is antenatal survey data. Survey estimates of HIV prevalence in pregnant women are not representative of HIV prevalence in the general population, but nevertheless, trends in antenatal prevalence might be representative of trends in HIV prevalence in the general population, which are important for determining the HIV incidence rates. There are those certain adjustments that you have to make in order to take the trends in HIV prevalence in pregnant women to get the trends in HIV prevalence in the general population. Typically, those adjustments would include adjusting for age and sex differences in the pregnant population, adjusting for the effects of HIV and ART on fertility, and adjusting for differences in sexual experience. But recent modeling work suggests that these are not the only factors that we need to adjust for. Recently infected women are more likely to be included in antenatal surveys than in surveys of the general population. And this is something that hasn't really been taken into account previously. This is illustrated in the next slide. This is showing results of some modeling work we recently did in South Africa. Here we are looking at antenatal bias on the y-axis, which is very crudely, this is a measure of the difference between HIV prevalence in pregnant women and prevalence in the general population. And on the y-axis, we have the average duration of HIV infection in pregnant women. The dots here are representing the results of different model simulations. And what you're seeing here is a very strong nonlinear relationship between the average duration of infection and the antenatal bias. When the average duration of infection is short, we expect to see a much greater degree of antenatal bias. And what that's really telling us is that a lot of the excess HIV prevalence in pregnant women is being driven by recent HIV infection. So this suggests that antenatal survey estimates of prevalence are quite sensitive to changes in HIV incidence. And this means that it's important for us to estimate the fraction of HIV positive pregnant women who acquire HIV recently. Fortunately, there have been a number of recent advances in developing point of care recency tests. And these could be very important in testing pregnant women. Firstly, so that we can estimate the fraction of pregnant women who are recently infected, which would tell us something about the extent of the antenatal bias. But also because this would help us to identify the women who are at high risk of transmitting HIV to their infants. You know, there's a very high risk of mother-to-child transmission in acutely infected women. Okay, moving on to case reporting. So central to case reporting is annual numbers of new HIV diagnoses. These can only really be estimated reliably if there's no double counting. And this is a challenge in surveillance systems that don't use unique patient identifiers. This has actually been probably the biggest obstacle to introducing case-based reporting in most African settings, that we don't really have a unique patient identifier. And the problem is unfortunately compounded by the absence of laboratory records for most diagnoses. Most of the HIV testing is point of care testing, and point of care results are often not captured electronically. But in the Western Cape in South Africa, there has been a pilot program introduced to digitize the results of point-of-care testing and link them to the provincial case reporting system. This slide is showing you the results of this study, and I really want to draw your attention to the last bar, which is representing the total number of positive test results. The dark green in that last bar is representing the number of positive results that were new diagnoses. The yellow and blue is positive results that were found after linking to the case reporting system to actually be people who had previously tested positive, so they were not new diagnoses. And so what this is telling us is that if we were to assume that all of the positive results were new diagnoses, we would be substantially overestimating the true number of new diagnoses. Another challenge to be aware of is that new diagnoses are obviously not the same thing as new HIV infections. So if we want to estimate HIV incidence from new diagnoses, we need to know either the rate of HIV testing or we need to know the stage of HIV infection at diagnosis. And unfortunately, it's becoming increasingly difficult to determine the stage of infection at diagnosis. We would normally determine this based on CD4 count. But getting CD4 count at diagnosis is becoming challenging, especially in the treat-all era, because it's no longer necessary to know a person's CD4 count before you start them on treatment. CD4 data is becoming less complete. And also with moves towards point-of-care CD4 testing, we are getting less complete data. So given the challenges with estimating the stage of HIV infection at diagnosis, we may need to invest more effort in characterizing the rate of HIV testing. And a number of models, such as the Shiny 90 model, are starting to do this. Importantly, this requires data on the total numbers of tests performed, not just the numbers of positive test results. Okay, moving on to look at geographic differences in HIV incidence. In subnational HIV incidence estimation, modelers often make the assumption that incidence is proportional to prevalence. But this assumption can be incorrect if a high proportion of cases in a district are imported from other districts, or if a high proportion of the incidence cases are exported to other districts. And you can see an example of this in the next slide. This is results from a recent study from Uganda. The bars in the middle here are representing the fraction of newly detected HIV cases in each district that are in migrants or immigrants to the district. And what you're seeing is that the bulk, more than half of new infections in these districts are amongst immigrants, which suggests that the current model assumption that incidence is proportional to prevalence is problematic. So models need to account for migration more explicitly. We need data on population movements, and this needs to be captured and incorporated more carefully into our current models. The same issue comes up when estimating HIV incidence in key populations, but here we are concerned with movements between risk groups rather than movements between locations. So the issue that we have here is that key populations have high rates of turnover. In other words, there's a lot of movement into and out of these key populations, and that's especially true for sex workers and people who inject drugs. This makes it difficult to determine how much HIV was acquired prior to entry into the key population versus after entry. And that's a challenge when modeling HIV incidence based on HIV prevalence data or data on new diagnoses. One possible way around this problem is to incorporate data on the length of time spent in the key population. And that's illustrated in this next slide, which is showing HIV prevalence among sex workers in Johannesburg, stratified by duration of sex work on the x-axis. The blue line here is representing a model fit to those data, and you can see that that blue line intersects the y-axis at a prevalence of around 35 to 40%. So that is very crudely suggesting that these women who became sex workers already had a prevalence of around 35 to 40% before entering into sex work. And that suggests that a lot of the HIV infection in sex workers may actually have been acquired prior to entry into sex work. Okay, so I want to finish off with just a few summary points from this presentation. Firstly, we need modeling approaches that can harmonize different types of data, both HIV prevalence survey data and case reporting data. We also need to change the way we use recency data from surveys in calibrating models. Ideally, we'd like to be able to calibrate directly to the lag positivity data rather than to the RITA-derived incidence estimates. We also need to change the way we calibrate to antenatal survey data, recognizing that the data are sensitive to changes in incidence and that a lot of the antenatal bias is linked to recent HIV infection. We also need case reporting systems that are based on unique patient identifiers, and we need to digitize point-of-care testing and link these point-of-care test results to case reporting systems. We also need to include migration data to estimate geospatial differences in incidence more accurately. And finally, we need data on the duration since entry into key populations if we want to use prevalence data to estimate incidence in key populations more accurately. And that brings me to an end. Thank you for your attention. I'm happy to answer any questions during the Q&A session. Thank you.
Thanks so much, Leigh. Just to emphasize what Leigh said, that you should, if you're attending the session, you should be able to access the chat function, and please post your questions on the chat function, and during the moderated Q&A session, we will be able to relay those to the speakers. The next presentation is a double team act. It's it comes from a team in Zimbabwe, who many of you may know. The team is Dr. Mugurungi, Dr. Owen Mugurungi, who's the director of the HIV/TB department at the Zimbabwe Ministry of Health and Child Care. And Dr. Mugurungi is also a co-investigator in the Mikaland Research Center for some time. And he'll be presenting with Professor Francis Cowan, who I'm sure many of you also know, who's a clinical epidemiologist and professor of global health at the Liverpool School of Tropical Medicine. And she's also the director of the Center for Sexual Health and HIV and AIDS Research in Zimbabwe. And both Dr. Mugurungi and Professor Cowan have been working with sex workers in in Zimbabwe for many, many years, and will be presenting some of the current research on that.
Hello, everybody. Good afternoon, good morning, good evening, and maybe even good night for some of you. It's wonderful to be part of this symposium and also to be in this AIDS 2020, which is quite different from the ones that we've had. We're looking forward to an exciting session on HIV epidemiology in Southern Africa, the critical questions and new methods, where we are going to be discussing what we can do to improve uptake, coverage, and retention in programs for sex workers. We want to start by reviewing the data from the last decade, and we'll end with a discussion on what else needs to be done to optimize programming for sex work. Next slide, Francis.
So I think I'm doing that, but for some reason it's not moving.
We all know that sex workers bear a disproportionate burden of HIV, which UNAIDS estimates to be around 21 times than the general population. We also in Zimbabwe have estimated that although the population of sex workers is small, but their contribution towards new infections in our country in Southern Africa might be between 40 and 80%. Next. So what we want to discuss is to make sure that in our countries, we have programs that work hand in hand with sex workers so that we can safely as possible make sure that their work is, they're empowered to do their work. And at the end of the day, we achieve the virtual elimination of sexual transmission of HIV through commercial sex work. And we know that for the past decade in Zimbabwe, we've been tracking what we've done. And I will now hand over to Prof. Cowan to take us through the journey of what we have done in terms of sex work in Zimbabwe for the past 10 years. Then I'll come back maybe a bit later. Francis?
Thank you, Owen. So you may remember back in the 2000s, the epidemic in East and Southern Africa was deemed to have moved from the general to the high-risk population to the general population. And modes of transmission studies suggested sex work was relatively unimportant in terms of a driver of generalized epidemics. And with that, funding for programs for sex workers was substantially reduced. In 2009, following a situation analysis conducted by NAC, National AIDS Council, and the Ministry of Health in Zimbabwe with other partners, Zimbabwe established a demonstration project for sex work, initially testing 2 program models established in 5 sites. Since then, the program has grown to 57 sites nationally. The Sisters with a Voice program is nested within government health clinics and is supported by an expanding and increasingly empowered network of sex work peer educators. Since the first sex worker was enrolled into the program in July 2009, all have been allocated a unique identifier, allowing us to track their engagement with the program. So as the program has expanded and become more complex, so have the data we collect. Initially, we collected clinical data from individuals plus summary data for community activities. But in 2017, we expanded our community data collection to individuals. Alongside the program runs a portfolio of research conducted with partners at LSTM, UCL, RTI, and includes the MESH consortium. This research has been critical for providing evidence for expanding and scaling the program at each stage. The data generated were unique in the region and stimulated program expansion in Zimbabwe, as well as more funding for sex work program more generally. The initial demonstration project demonstrated the high risk that sex workers were facing and their poor engagement with care. Among the first sex workers who agreed to be tested by the program, prevalence was 80%. We conducted our first RDS survey in the region in 2011 and found prevalence at 3 sites ranging between 50 and 70%, and that there was poor knowledge of HIV status and low treatment uptake. We were able to expand the scope of programming geographically now to 36 sites, and in terms of service provision. We were able to nest within it a cluster randomized trial of targeted combination prevention, which provided more nuanced understanding of both treatment and prevention cascades. We confirmed what we knew from our program data, that young sex workers were even more poorly engaged than older sex workers in both prevention and care. Using these data, we were able to raise additional funding to support development and rollout of a program for young sisters. Analysing data from repeat testers in the program, we showed that HIV incidence was 20 times that in the general adult population of women, and that younger sex workers have particularly high incidence. The funding environment began to shift in 2016-17. PEPFAR and Global Fund became increasingly engaged, allowing further scale up of the programme. Additional research studies were conducted to guide programme development further. So just quickly to provide some examples of some of the analyses we've conducted over the years. Here we show testing data from the largest site in Harare between 2009 and 2017. And just to show that you can see the proportion in blue of people who have never tested when they're engaged in the programme has become vanishingly small, and the proportion of negatives who've tested recently, for example, has grown proportionately, as shown in green. Here you can see data from the study I mentioned earlier in repeat testers in the programme. You can see incidence is shockingly high at around 10%. Combining data collected through repeat respondent-driven sampling surveys between 2011 and 2016 in 19 sites around the country has allowed us to see trends in engagement with the treatment cascade. Prevalence has remained relatively stable, while knowledge of HIV positive status, uptake of treatment, and rates of viral suppression have all increased, but are still short of the 90 targets in the majority of sites. Although I just want to point out that in a few sites we had already achieved 90-90-90 even in 2016. Triangulating population size estimates from 16 sites with programme and census data, we established Zimbabwe's first national population size estimate, which is around 40,000 female sex workers, estimated at around 1.23% of the adult population of women. These data have been used to develop programme targets and to allow us to better estimate programme coverage. We know from anecdote that sex workers are highly mobile, following clients both across Zimbabwe and further away across the region. A mobility survey nested within the RDS surveys for the CeSHHAR trial in 2013 and 2016 confirmed that internal mobility was high and had increased quite substantially between 2013 and 2016, likely due to the worsening economic situation in the country. We found that around 20% of sex workers travelled internationally on a regular basis, and that healthcare engagement is dependent on the context of travel. These data have informed the development of travel preparedness intervention within the programme and a regional cross-border programme for sex workers. In addition to these studies, we've analysed survey data to explore the interplay between condom and PrEP prevention cascades, to look at the impact of targeted combination prevention, and to evaluate the impact of DREAMS plus PrEP for young women who sell sex. And I just want to call out that Sungai Chibata has an oral presentation presenting the DREAMS work later on in the conference as shown in the slide. So over the last decade, a lot has been achieved. Hand in hand with sex workers, the Sisters programme, coupled with the Zimbabwe government's national prevention and care programmes, has brought about substantial achievements. The programme is one of the few nationally scaled programmes on the continent. Its scope and implementation is informed by evidence, and sex workers are better engaged with services than before. Several sex worker-led CDOs have been established and are starting to take on community engagement and empowerment activities. The data generated have been key to attracting funding to scale up the programme and develop and test a range of programme innovations, including HIV self-testing, self-help groups, educational subsidies and mental health interventions. Despite this, coverage is not yet universal, and we are still short of the UNAIDS targets. So over to Dr. Mugurungi, who's going to talk through the next few slides.
So the next slide is now, what more do we need to know? So we know that in recent years, we have had a shift in the proportion of funding that is coming for prevention and also focusing on key populations. We know that the Global Fund, which is a major funder for our country, will in the next 3 years will be prioritizing work among sex workers to ensure that they are optimally engaged in comprehensive programming that include support for prevention and care. Next. So we feel that through empowering and working closely with sex workers, we may be able to achieve our desired goal of virtual elimination of HIV transmission through commercial sex. Next. And how will the program need to evolve for us to reach such a target? First, we know that sex workers need to be further engaged and empowered and supported to make sure that they understand and identify their vulnerabilities, the shame and stigma and discrimination that make it difficult for sex workers to engage with services and optimize their access. Uptake and engagement will also need to be dealt with. And we also know that services will need to be more accessible for all sex workers, including those that are specifically vulnerable, which include young sex workers at the beginning of the sex work. Next. So we also need to understand who is at risk and where. And this is where real-time data analysis can be used to understand the trends over time and place in testing, yield uptake, incidence, prevention and care cascade, population sizes, etc. We can also incorporate the recency testing integrated into program testing and algorithms, which will also identify for us the geography and the trends over time. We'll also be targeting prevention of HIV in hotspots of transmission, and also look at the place studies that will also identify the high-risk men and women and the program engagement in terms of prevention and care cascades. This will make us sure that we intensify and allow us to provide services that can be useful for our sex workers beyond what we are providing. Next. It is also highly and critical that we continue to provide pre-exposure prophylaxis, and we know that offer and initiation is not enough. In the previous slides, Francis presented that the incidence of HIV amongst our sex workers is very high. So scaling up PrEP among sex workers has the potential to reduce their high risk of infection, and also we will also need to make sure that we have evidence and strategies that support the uptake, continuation, and adherence to PrEP amongst these sex workers. And unlike antiretroviral therapy, where we know that treatment is for life, we know that the treatment, the PrEP, might be useful in terms of a short period, and we will need to make sure that it is understood by all sex workers, and we provide the support necessary for them to utilize and use it. The PrEP cascades can also be useful in terms of identifying barriers to motivation, uptake, and continuation or discontinuation of PrEP. We also need to make sure that we expand the use or introduce the use of long-acting PrEP that when it becomes available. I'll hand over again back to Prof. Cowan.
Okay, thank you, Dr. Mugurungi. So, Dr. Mugurungi's just mentioned that unlike art, which is for life, PrEP is taken to cover periods of risk. Risk is dynamic, and the extent to which risk varies over the life course of sex work is poorly understood. Leigh mentioned earlier that sex workers may move in and out of sex work, and sex workers often report, for example, that they've discontinued PrEP because they no longer need it. They've got married or they've stopped selling sex, only to resurface in the services a few months later. So we're planning to undertake some longitudinal studies to better understand sex workers' seasons of risk, following around 200 sex workers in Zimbabwe and 100 in Malawi and South Africa over the course of a year to answer some of the questions on the slides. And we think that this will be useful both in terms of designing programs for supporting PrEP and for informing models. Through tracking unique identifiers of sex workers who visited the Sisters programme in Zimbabwe, we know that around half only visit the programme for clinical services once, but we don't know what happens after that. Do they stop selling sex and no longer need the services? Do they seek the services they need elsewhere? Have they moved out of the area or the country? Or have they discontinued using services despite continuing to need them? We're in the early stages of a tracing study among 1,200 sex workers in 3 sites to better understand service discontinuation and whether sex workers who are still in need of services can be supported to re-engage. Our initial pilots suggest that tracing may be time-consuming, but if it does result in improved coverage and retention, it may be subsequently introduced as a programme strengthening activity.
Francis, you've got 1 minute left.
Okay, so tracking trends in incidence in a representative sample of sex workers over time and space is problematic, and there are different biases inherent in different approaches. I won't spend too long on this slide, but triangulating incidence measures gleaned in different ways and using different data sources, we hope to be better able to track incidence and define where and which sex workers are most at risk. Andrew Phillips and colleagues are helping us explore, in terms of ART, PrEP and condom uptake among sex workers, what we need to achieve, what uptake we need to achieve in order to reach virtual elimination of transmission through sex work. So in summary, real-time triangulation of data collected from programs, surveys, other new research types of studies and modelling should be used to inform and guide our epidemic response. I think in the next 3 years, we will finally, as a country, have the funding to be able to really engage with sex workers properly and using data to guide how we do that best will be really important. I'd just like to say that I've presented data on behalf of a huge number of people, and of course on behalf of Ministry of Health and National AIDS Council. I'd really like to thank all the sex workers who've taken part in the research and the programs that we run. We work with a large number of academic institutions and other implementing partners. And of course, none of this would have been possible without the support of our numerous funders. So thank you.
Thanks so much, Francis and Owen, for that presentation. We don't have an enormous amount of time for questions, but I'm going to jump right in. And thank you for people who have sent us questions already. So Leigh, the first question goes to you, and it's a question about the importance of recording deaths due to AIDS as part of the case reporting and to improve modeling. How important do you think that is, and is that something we should be aiming for in African countries?
Thanks, Saul. So it's something that I touched on in the context of the case reporting approach. And usually in case reporting, it would be required for estimating prevalence. It's perhaps less important for estimating incidence. But I think where it does potentially become very useful is if you have age and sex disaggregated mortality data that can tell you a lot about the age and sex pattern of HIV incidence, which you might be lacking from either HIV prevalence surveys or routine diagnoses. So I think it is potentially an interesting additional source of data that could strengthen our incidence estimates, and particularly the age and sex pattern of HIV incidence estimates. But I think the big challenge we face in many African countries is that vital registration systems are very weak. A lot of deaths don't get recorded, and even when they do get recorded, the cause of death is often poorly recorded. So I think we have a long way to go in terms of making use of the data that could be collected in our models. But it's something that we need to push for, not just in the context of HIV, but in the context of monitoring progress towards other sustainable development goals.
Thanks so much, Leigh. To Owen and Francis, there's a question about, it seems that when women come into sex work, they already have quite high HIV prevalence. And so there's a question about, does this represent the fact that these are already women possibly engaged in transactional sex before they are considered to be sex workers? Or is this as a result of just background high rates of infection in the communities?
So I think there's high prevalence in some sex workers when they start selling sex, but not in all. So we've done surveys in very young girls, 16 to 19 years old, and their prevalence starts off at 2% and rises to 27% over the course of a few years. So very young sex workers do not have high rates of HIV when they enter sex work. Women who start selling sex when they're older are in a different position, and they have very high rates of divorce or widowhood. And in fact, they may be entering sex work because they have a partner who's left them when he's HIV positive or who's died of HIV. So it is possible, although we have not yet been able to define this absolutely, that those women have high rates of infection at the start of sex work. But I think it's not a universal truth.
Thanks, Francis. I'm not sure, Owen, did you want to add anything? Or?
No, not at the moment. I think Francis has answered it very well.
Thank you. Leigh, a question to you. You spoke about the recency assays, and in some ways we're all chasing that holy grail of trying to identify incident infections and what that can tell us about the state of the epidemic. But you've very adequately, explained what some of the challenges with the recency assays. You implied that it would be better for modelers to actually get the raw data without it having gone through the RITA algorithm. And I just wonder how easy that is from the fear surveys and other surveys. How easy is it to get that data, and how can that be addressed in some way?
Thanks, Saul. It's a good question. I think it would have to be done in partnership with the people who run those surveys, so people at CDC and ICAP who've led those surveys. I think we would need to work in partnership with them in order to access that sort of detailed data. But I think in principle, it should be possible. It would be interesting to do a comparison of how this approach, where we try to calibrate our model to the actual raw data, compares with an approach where we just calibrate to the RITA estimate.
So that was me hinting, and I hope some of them are on the line. If there are people who run the fear surveys or other surveys, if you can release some of your data for that purpose, I'm sure that would be helpful. Another question to Francis and Owen. You presented some of the 1990 results, and so both the treatment cascade, a bit on the prevention cascades for sex workers. And I wonder, given that it's such a priority to get sex workers onto treatment and ensure they're virally suppressed, does your data show where the gaps are in the cascades, either on the treatment or the PrEP cascades, that allow you to program? And if you could, in an ideal world, what would that data look like?
Do you want to have a go at that, Owen? You shy?
The biggest gap that we tend to have it in our prevention efforts. In terms of the number of sex workers that get access to HIV testing and also know their HIV status. I think that's one of the gaps. And it tends to be much more amplified in young sex workers. Having said that, we also realize and know that we need to do more in terms of our prevention. And as Francis said at the beginning, that when you look at younger sex workers, the HIV prevalence is still lower than in older sex workers. So we have an opportunity to work closely and empower them and make sure that they get involved with HIV prevention, condoms, PrEP, etc. But we are also concerned on the other end that in terms of access to treatment, we are also found wanting. The major challenge there is the shame, the stigma and discrimination, and the structural and other barriers that prevent these sex workers from seeking out proper healthcare services from anywhere within the country, because they are discriminated and they are blamed for other issues. So you also tend to find them not coming out once they know they are HIV positive to seek out to get the medication that they probably require. But certainly, we still have lots of work to go through, and I presume our biggest challenge is to make sure that the environment is more conducive for us to work with them and also for them to access the services. This is why we feel that engaging them and getting them around the table and them dictating or at least telling us what kind of service they require will make it possible for us to move forward. But we have a long way to go, because we still have laws and issues around the movement and how we treat our sex workers in Zimbabwe. Maybe Francis, you can then finish it off.
Just to say, I think that you answered that very comprehensively, but just a couple of things that we're doing with our new programme funding, we hope going forward, which has been substantially expanded, is we're hoping we're going to be allowed to do art initiation on site and then transfer people for their longer term care to the clinics near where they live, so that we can start people straight away. In self-testers, that's been really found to increase uptake of treatment. The DREAMS programme is being expanded beyond the current districts, and special provision is now being made for young women who sell sex within the DREAMS programme. So we hope we can reach younger women more easily. And then I think the third thing to say is we're setting up crisis response teams so that we can, if we find people in crisis, we can try and intervene before they become infected or too vulnerable.
Thank you both. We're almost out of time, and they're so strict with these online virtual symposia. So we've got about a minute left. So I just want to thank everybody for participating. And again, I want to urge everybody, if you can, please go to the pre-recorded session on IIS or MESH websites. The MESH has got a new website at mesh-consortium.org.uk. There is a JIS special edition on using data for HIV prevention. Hopefully there are lots of resources, additional resources, looking at data, better use of data, the HIV epidemiology, and how we can really improve data. As always, I think what all of us are trying to do is really improve data to drive better programming and improve our prevention programming, even in these quite difficult and uncertain conditions in which many programs find themselves at the moment in the COVID environment. So I just want to thank everybody for attending, and I hope you found it helpful. And all the participants, thank you so much.